very much, Professor Anju Dhawan, for covering widely and also in focus, taking us through from 2004 to and also covering the data from the India in the various setting from the school children, street children, and also the different setting, and also the talk the world data and the western data, and also covering the risk factors and the preventable factors, and finally giving the broad suggestions how to overcome this thing. Thank you so much, madam, for the lucid talk. With this, I now invite our second speaker for the session, Professor Arun Kandasamy, who is currently working as a professor and head of the department for the Center for Addiction Medicine at NIMHANS, Bangalore. And Professor Arun has a large and wider area of interest, starting from the ranging from the adult ADHD to the behavioral addiction to the vulnerable youth mental health, and also psychosocial intervention focusing on the addictive disorders, including that of the course and outcome, and interestingly the physician and mental health. And his major achievements includes nearing 100 national and international publications, and nearing 40 funded and unfunded projects, including some prestigious awards and medals originating during the studentship period, like Tilak Venkarao Gold Medal, and RLN Murti Rao Award, and Fellowship of the Young Asian Psychiatrist of the Asian Federation of Psychiatric Association, and many more accolades. With this, I warmly invite Professor Arun to start his talk, please.
Dr. Sushant, respected seniors, colleagues and friends, at the outset I would like to thank Professor Basu and the organizing team of the National CME on Addiction Psychiatry at Department of Psychiatry in PJMR for inviting me to be a faculty in this program. Thank you very much, sir. My job is being made simple because from the morning we have been hearing about how there are issues with children and adolescents and how the problem starts very early, right from Professor Vivek Lal, director of PJMR, and Professor Pratima Murthy had alluded into the same. And my job is even more simple after Dr. Anju had put in everything in perspective. I'll try and see how I could make it as interesting as possible, because I know that it's a post-lunch session. Now the glucose level would have hit. So one disclaimer, I do not work with alcohol, tobacco, gaming or gambling industry. I would like to split my presentation into three sections. One is keeping with the theme of the CME, looking at the realities and challenges, and section 2 is to look at some of the conceptual understanding of addiction, because if we ought to ask something, we need to know why we are asking. If we don't know, we will not be able to ask it. Section 3 is to the management approaches in the clinics. For the reality and challenges, ma'am had presented all the national level data. I would take the data from our own center and tell why we are doing what we are doing. Now, we have collated data of around 27,000 individuals of all ages, and we tried to split them into those who belong to under 19 and under, and those who are above. One interesting thing which we could find was that the profile of substance use in these populations are very different. Predominantly it is alcohol in the older or adult group, but the adolescent group, alcohol and cannabis goes neck to neck, then inhalants and opioid. This is the kind of clients which we see in our group. And as Dr. Anju had pointed out, the use starts from somewhere between 12 and 17, and it takes between 13 to 18. Within a year, they seem to become addicted once they start doing it. I hope we can do monitoring the future study to look at the data to say that like every year reduction or every year early they start, there is the higher chance of getting addicted to it, but unfortunately we don't have it. As madam had pointed out, this question was asked in our clinic also. Among the adult treatment seekers, almost 2/3 of them have started their substance use under the age of 19, and 40% of them had become dependent under 19. So obviously, even in that population, even the adult population, most of them are younger when they start and have problems. And these are the complications which they run with. Uh, the deliberate self-harm attempts are quite high in the younger age group, but other medical complications are relatively less. So we still have the capability to reduce the harm in these population if we address it early. The same thing which comes up. But the functionality dimensions in various dimensions of anybody's life, it seems like the damages are on par with the adult group in adolescence. In comorbidity, affective disorders seem to be significantly higher in this group, which is the under 19 group. We also looked at the vocational status of them. Almost 50% of them are school dropouts, and again, another 50% of them seem to be working in some semi-skilled or unskilled jobs. 50% of them are not doing anything. This is another area which we need to focus on, because dropout and can be reduced by improving the school retention. And looking at the vulnerability factors, two factors we tried focusing on, because other assessments we couldn't trust, but these two are easy to look at because we regularly ask it. Significant proportion of them have family history of addiction in adolescent group, and significant proportion of them have temperamental difficulties also, various temperamental difficulties. So obviously this group is specifically vulnerable even in their early age group. And the other treatment issue is that almost 50% of them are in denial when they come to the clinics. They are not willing for taking any treatment when compared to 20% in the adult group. So again, this is a highly reluctant group for seeking treatment. So to summarize this section, adolescents are a high-risk group of addiction and other related issues, and are reluctant to seek treatment. If they can be identified and treated earlier, we could reduce a lot of complication consequences. We need to consider the challenges which is thrown to us as opportunities also, otherwise it will become too nihilistic over here. So moving on to the section 2, conceptual understanding of addiction, and it's relevant to the current social milieu with respect to both children and adolescents. Now, this is the illusion with which I work, and my boss also work. So we believe that evolution of addiction is like a story, right? Addiction doesn't happen without any underlying issue. Addiction is only a tip of the iceberg. So we believe that everybody who presents to the clinic with either addiction or high risk behavior, they have a vulnerability component to it. Those vulnerabilities could be biological or environmental. Biological vulnerabilities usually are being put into family history positivity, temperamental difficulties, and the environmental difficulties could be developmental stressor, right from poverty and parenting related issues, family problems, undergoing some kind of neglect or abuse at early age. So all these things would come under the vulnerability angle. Not all the people who have vulnerability seem to develop psychopathology. So this vulnerability, when that meets with something called as the proximal antecedent, it could be a poor academic performance, or it could be poor relational performance, or it could be some exposure, right, in form of abuse or anything which happens at that period of time, makes them vulnerable. And once these two meet, we believed that the psychopathology get manifest, and then the addictive behaviors happen over here. And the addictive behaviors are only one part of this expression. It could be other high-risk behaviors in these people, and they are very prone for having high-risk behaviors. And it could be comorbid other illnesses, externalizing or internalizing illnesses too. And this, when continues for a period of time, results in something which is complications of this addictive behavior or the high-risk behavior per se. So we usually teach that the story has to be said from vulnerability to the proximal antecedents and psychopathology and consequences. It's easy to remember and easy to construct interventions too. So we tried doing another small work with people who have gaming behavior, and wanting to look at gaming as a normative phenomena, because most of us are seemingly gaming also. So what we did was we interviewed normal gaming, recreational gaming people who are professional gamers, people who have gaming disorder, their family, and gaming developers as such, and looked at different aspects, say how initiation of gaming happens. Not necessarily it is problematic initiation, even normal initiation also, and then looked at the rewarding aspects also. We got some results, and we see that most of them have increased online gaming also because of various internal or external reserves when it get affected. But what was interesting to see was that here also we could find there are risk factors in them, there are protective factors in them. The risk factors are usually having internalizing disorder, externalizing disorders, lack of alternative activities like in COVID, boredom, difficulties in school and workplace. These were the risk factors. And there were protective factors in them, like say balanced lifestyle, family support, and active social groups, self-regulation, adequate and appropriate parental control. These were protective factors. So there was a balance between both. When the balance was tipping towards protective factors, they were able to control the gaming, they could delete it and then reinstall it at a later point of time when they need that reward. But when the it tipped towards the risk factor, they end up in having pathological gaming and related consequences. This is what we could identify in the group which we had gone, and this is a proof of pudding for our own delusion what we have till now. Now, this is something which was talked in the morning also. So there is always in the human mind, there is a struggle between balance of pleasure and pain, right? And this in this balance, always people would look for pleasure and pleasure principles quite often. Like now, this is an era of indulgence and abundance. We have infinite access to stuffs. Now, this had led on to maybe it is my own belief system, but then if you look at it, this is a YouTube channel. If somebody wants to look at people who have addiction or high risk behavior, I want you to visit this channel and listen to these interviews. These are people who have done things which we can't imagine, right? But the trajectory follows exactly as I described. Most of them had very, very different childhood compared to many of us, and their childhoods were quite affected. And then how they become whatever they are in adult, how it progresses. Like this has actually again validated our own belief that it starts from vulnerability and then proximal antecedents and then other aspects, the psychopathology and consequences. So we have solidified our delusion that evolution of addiction or other high risk behavior is a combination of biopsychosocial vulnerability with infinite access. When they both come together, they result in expression of the phenotype, which could be addictive behaviors or it could be other risky behaviors per se. Now, with this, we need to move forward with what do we do? Obviously, there's no magic man over here, and it's not easy. The issues are multi-sectoral, multi-pronged interventions are needed over here. But opportunities don't happen, you have to create them. So that's where we come to the management approaches in the clinics. I'd split it into 1, 2, and 3. If 1 is understood better, and 2 little lesser, but the third will come on its own. The first one is creation of rapport or therapeutic alliance. I always felt that my job is not any less when compared to a cardiothoracic surgeon. They usually talk about how they take the heart out and then they put inside whether it's going to beat again or not, they have a problem. But the same kind of anxiety I also have when an adolescent walks inside my clinic. Whether I'll be able to create a rapport with this client at all or not. This is an everyday difficulty as such, because 50% of them it happens, but 50% of them they feel that I'm whatever it is. And I'm frank in saying that this is the failure rate is quite high over here. But we need to understand this part. It may be difficult, but it's one of the most important steps in our intervention, in the management. And there is no end point. Many people ask, like, when do we consider that the rapport is created? There is no end point to it. Like, it needs multiple sessions, right? And then how do we achieve it? Some of the tips which our seniors have taught us: non-judgmental attitude, active listening, not being defensive, some of the things I have learned is my urge to give them solution, right? The writing reflects as my consistent response. I have to control that. It's over a period of time. I'm still learning. It's not that I've learned it. Like the second one over here I've written is being honest, because some of the times I don't know what they're talking about, because I'm from a different generation. They are from a different generation. I don't know. If I don't know, I ask them what is it, because they feel their narcissism also get fed by that, and they start telling me what they are going through. I listen to them. I ask all the questions, but then I cannot go with the lack of knowledge to the next session. Then the relationship balance is tilted. I need to be prepared for the next session, but in the first session, being honest and saying I don't know, it's good, because most of them will go out and say that this fellow is goofing up. He doesn't know anything, right? It's better to be open and say that I don't know what you're talking about. And because the lingo keeps changing, right? What is because whatever my daughter says, I am still not able to understand, because she's 13. So there are certain things which she uses. I need to know why she's saying that and what does she mean by that. So we need to speak their language also. Through this, we can attempt at creating a better therapeutic alliance or rapport. Now, this is a seminal paper which was published in 1971. If any of you have not read, please go back and read it, because this is the core of treatment in psychiatry, right? We can call it as common factors approach also. But Jerome Frank has nicely put up how the content is not important, how you, being the therapeutic, how that is important over here. One of the factors which he points out is that you need to reframe the problem into something which looks novel. It may be the same problem, but you need to give a novel way of explanation to them, and that makes them to stick on to you, right? This one, reframing the problem, is something which I do often, and I find it quite useful in the 50%. Okay, let's move on to the comprehensive assessment. Again, as I said, a good comprehensive assessment means it is a therapy by itself, because there are a lot of insight facilitation which happens during that point of time, not only for the client but for you also, because you know what might work with this client, what may not work with your client, right? Here we use something called as ABC technique. Again, the same model which I used earlier, from the vulnerability to psychopathology to consequences. Here you start with the antecedents of vulnerability, then move on to the behavior specific, which is addictive, and then move on to the consequences or comorbidity. Remembering this way is easy for you to make the phenotype to be presented better. It's useful both in exams and also if you're a practicing physician also to follow it up, because stories get embedded in our mind faster and easier. All of you know about this, looking at the first part of assessment of addictive behaviors per se, whether it is substance use, gaming or gambling, or any other problems as such. We need to see how it started normative and moved on to the addictive pattern, looking at type, quantity, frequency, current pattern and mode of use, all those things. Then you move on to initiation factor, maintaining factor, factors affecting lapses and relapses. And one of the most important thing which MI has taught us, and we also need to practice, is we need to learn the art of asking how that particular behavior is helping the client. If we are able to do that, and if we are able to elicit the answer from the client, I think we should feel proud of ourselves that we are becoming a good interviewer. Because most often Indian clients would say, no, it's not helping. It's a pleasing answer. But why are you doing it? Right? Unless we understand why they are doing it and how is it facilitating things in their mind, we won't be able to do enough. Right? And then looking at current motivation, the factors which need immediate interventions is something specifically we should address, because this is a low-hanging fruit. By plucking this low-hanging fruit, we may be able to create a better rapport, because a particular distress we could address. So, and that creates a kind of rapport with you and the client. So, look for factors which could be, you can treat immediately. And again, wherever physical examination and laboratory investigations, you should do. Sometimes laboratory investigations are used as threat. I would advise not to use in this population, because that's going to be counterproductive. It's not about the pathology with respect to addictive behavior. The non-addictive behavior pathologies also need to be looked at. Cognitive control, how one finds it difficult to control certain aspects of life. Rejection sensitive dysphoria, very high in our population. If we start asking it, we will be able to elicit this quite often. Negative urgency, the impulsivity which one tries to control, not able to control also. Experiential avoidance, where obviously the pleasure and pain part of it, pain, don't want to face it, use a coping strategy which is useful for them. Loneliness or anomie, it's something which is I'm not able to quote the data over here, but some of the metro surveys which has happened recently through NMHS, we could find that there's a lot of unemployment, anomie is being seen in the younger lot, which could also factor in as something making them to move towards these behaviors which can give them immediate reward. Perceived stress is very high in this population, right? So we need to elicit. For them it is stress, but for us it may not look like. We have to understand how they perceive a factor as stress. Other high risk behaviors, deliberate self-harms had to be specifically asked, and functionality, right? Functionality in different dimensions of their life. Complications, physical, mental, social and legal. Comorbidities, psychiatric comorbidities from the internalizing sides, externalizing side, psychotic side. Do not forget about asking medical comorbidity, although in this population it may be less, but still we need to ask. Especially those who have family history may have a higher chance of developing medical comorbidities. Temporal sequence, if it is availabilities of use to determine how the treatment strategies are going to be. There are various parenting and family factors. One is that substance use or mental illness in the family itself, single parent family where there is neglect which is happening, what kind of interaction between the parents happening, what kind of interaction with the parent and child is happening, like how the support system is, and how they interact with their own siblings. And there is something called a child-headed house, which is street children and children living in homes where they are the lead of their life. Aggression in the family and neighborhood, adolescents who have already being employed and have spare money in their hand. So these are the parenting and family factors which are similar. And we all know Bauman's different kinds of parenting. We know that at least researchers have clearly pointed out permissive and neglectful parenting is more prone to push people towards substance use. There is a debate between whether authoritarian parenting is helpful or not. Of late, researchers are saying that authoritarian parenting is not so bad. That need to be taken into account. Again, developmental stressors, adverse childhood experiences, need to ask for it, because once you get that comfort and once they talk about it, the rapport is at a very different level. Once they are able to talk to you about the kind of adverse childhood experience which they had gone to. We gave extra importance to that part of it, looking at temperament. Temperament as a mediator in terms of development of psychopathology. Internalizing pathway, where the distress is expressed internally most often, which results in low self-esteem, depression and anxiety, subthreshold levels, being passive or passive-aggressive, procrastination, avoidance, poor communication skills, etc. And then externalizing pathway, where distress is expressed externally, mostly on ADHD side, conduct disorder, oppositional defiant, and some of the ASP traits. Emotional instability comes out very significantly over here. Higher novelty seeking and low harm avoidance is usually seen. Interestingly, at one point of time, I used to think that these two are existing in silos, but over a period of time, I've realized that majority of the externalizers do have internalizing component also. If I address only one, I always feel it's of no use. I need to look for both and address both. But after we start seeing behavioral addiction, we got into this also, this psychotic or autistic spectrum of temperament. Now, we had sort of got hit a wall with many of these clients as such. And then we went and looked for these traits specifically. We found that many of them are seemingly having this also. When with this and this, our mind started knowing this, our eyes started looking at the same in others, in regular substance use disorder also. And we feel that quite a few of them do have this also. We need to factor in this when we are creating interventions for their clients. This might be the reason why some of our clients we are not able to achieve adequately. So then we may have to change our interventions. So when it comes from management of addiction, obviously it starts from vulnerability, move to consequences. But when it comes for treatment, it starts from consequences, treat the consequences, which is easier, and then the psychopathology, and then the vulnerability part of it. It goes on the opposite direction. So the step 3, treatment. How much more time I have? 10 minutes? Oh, thanks. Enhancing motivation becomes the core, and then we need to treat addiction and its complication, vulnerabilities, comorbidities, and also focus on alternative pleasures. The treatment approach, one size doesn't fit all. It has to be tailor-made. This is one of the difficulty which I'm still, I'm growing in the field of treating adolescents and even adults with addiction, that we need to tailor-make it for each client. There are two kinds of treatment model which is being discussed, complete abstinence and harm reduction. But in truth, in India, none of us practice this exclusively. We use harm reduction to move towards complete abstinence most often. This is a model which I tried using in my mind, and also I tell my clients, and I teach also. So I equate treatment of SUD to learning ballet. For learning ballet, there are 4 things which are not. The motivation to learn ballet, the infrastructure which in the form of the attire, the flooring, that is needed. I need a coaching. Just because all these things are there, I am not going to learn ballet. I need to keep practicing it. Same thing I try to apply to my treatment over here also. First is motivation, both through education and MI. I need to improve the motivation part of it. The infrastructure, I would equate that to medicines, which set the stage for us to work on the behaviors. Psychosocial interventions become the third. Just because the setting provide all these things, it doesn't mean that the client is going to improve. Unless the client is going to regularly practice it, it's not going to be of use. So this is how I understand the management model for addiction. It is essential to say combination of pharmacological and psychosocial intervention is essential. None of it is superior to the other. Interventions focusing on the immediate client. There are 3 factors apart from what I've discussed, which I want to say. Establish mutual trust or rapport. Second thing is, as I said, identify a common treatment goal. Even if 50% of them are not coming with a motivation to change, it is our duty to find some way of working with them. It is that they are angry with their family, or it is an academic help. Somewhere you need to find a common treatment goal. It is individually different, so that you will sustain engagement. Once you sustain engagement, there is always a higher chance of them getting out of this cycle of addiction and other high risk behaviors. Treatment of immediate issues, pharmacological, overdose management, intoxication management, and withdrawal management. And most of the medications for long-term management of substance use disorder in this population, the evidence base is less, but we are using as per any patient's need. Again, the same with respect to comorbidity also. Some of the intervention which have been tried and found to be helpful in this age group are MET, CBT, and also brief motivational enhancement programs, mindfulness based relapse prevention, self-help groups. CBT for gambling and gaming has been used here. One of the things which I also commonly use is looking at alternative behaviors. Just because you remove one thing, there is the need for the reward is still there. So how are we going to modify it? How are we going to give a different forms of alternative enjoyment, alternative pleasures, right? So we need to work on that part. Intervention for externalizing disorders, right from nutritional supplements to stimulants to all sorts of alternative and complementary approaches. Intervention for internalizing spectrum disorders from SSRIs to CBT. Broader spectrum, one of the very difficult area to work. Treating the comorbidity, by that you reduce some of the morbidity and then break down the tasks into simpler, ones, and finding rewards for them is the most difficult part of it. Without that, contingency management wouldn't be possible with them. Personality-based intervention should be a part of it because many of them do have personality comorbidity also, especially emotional regulation, maladaptive schemas, and enhanced relational effectiveness. Transdiagnostic targets, which I mentioned over here, most of our clients do have this, whether they are internalizing or externalizing. Now, this, if we are not addressing it, when they go into the real world, they find it difficult to handle their day-to-day life, and then the only solution which they have is to go for their abnormal coping strategy per se. Developmental stressors interventions, quite a few are there, and we should adapt it based on the client's need. Peer influence is always found as a problem, but this also need to be looked as an opportunity also. Teaching the child how to choose their peer and how not to, right, and how to be assertive over there, that is one thing. The other is how in the group they should be taught to learn behaviors, right, rather than not using it a lot, rather than blaming peer influence every time. This is an opportunity for us to make them learn better behaviors. Yeah, relook into the opportunities of peer influence. Parent family therapy is one of the very difficult part because they have come with high expectation. They want tomorrow the client need to be better, which we cannot produce. So we need to keep working with them. Sometimes the kid will not come. It doesn't mean that the therapy ended. So you need to find surrogate therapists in the family who could take forward what work which you could do. Quite a few of my clients got helped by this. And later point of time when they are ready, they had come also. This is a module which we have developed. Again, parenting, it's not possible to connect when you are adolescent. The connect has to happen earlier so that we can make use of it during adolescence. We need to model desired behaviors. We need to teach the family to give and take control of decision making. Normal routines need to be monitored. Risk taking is considered as necessary, and find ways to take risk. Role play about risky situations would help. Always there should be a backup plan, should have some support. Do not go alone. As Madam pointed, know where the kids are, what they are doing, return to family basics, and learn together and play together. Community-based intervention, there's quite a lot of it. It's just to say, encourage skill building through group risk taking so that the community can have activities which help them to do such kind of activities. And I will not be able to cover this part. So this is a better document to look at, preventive options. I would urge you to read all those. So to summarize, psychosocial factors and the background of biological vulnerabilities contribute towards the evolution of addictive disorders and other risk behaviors. So we need to have a comprehensive and meticulous evaluation of these factors so that we can tailor make the management for our clients. And we need to look for transdiagnostic intervention, transdiagnostic targets and intervention so that we can do it at a larger scale. This is a summary. If you're assessing, move from vulnerability to consequences. If you're treating, start from consequences to vulnerability. Always listen first.